Hi, sir.
Hi.
Thank you for taking out some time to talk with us from your busy schedule.
Pleasure is mine.
Okay, sir. Sir, please tell me about yourself.
I'm Dr. Rudresh. I'm professor and the head of the department in the JSS Medical Hospital. For the last 5 years, I'm working in this hospital. I do most of the non-vascular interventions. I'm not much into the vascular interventions, and I do have a preferential. I do like something like neuroimaging and a gastroimaging, but I do most of the things.
Sir, so what initially drew you to the field of interventional radiology?
The field of the interventional radiology, I took it because as a postgraduate, we need to do a thesis, and fortunately, I need to say, my guide, Dr. Ashok A, he gave me one of a thesis topic which was mainly the hepatic interventions. So once I started my journey in the radiology as with a thesis of interventions, I really appreciated how we can just keep treating the patients, not doing much of cut sections over the patients.
What do you find most rewarding about the work?
About the intervention, you mean
yes,
to say?
Sir.
Compared to all others, with due respect to the surgeons and other fields, when as an interventionist it comes, we are too minimal to intervene. We don't go into the significant cuts or abrasions or anything, and we give almost more or less accurate treatment with less incisions, which makes the things easier for the patient. The patient goes without any scars over the body, less scars, and they are almost perfect as soon as they go, and on a daycare basis most of the procedures are done.
Yes.
That's good for the patient, less expenditure.
Could you describe a particularly memorable or a challenging case highlight that you have encountered in terms of interventional radiology which can have a better patient outcome?
Yeah, it's a good question. To be frank, I consider each and every case as an interesting case, because whenever I do interventions, we don't take ourselves something like a radiology. Most of the times what happens is the radiology are considered something like behind the screen workers. We are considered something like off screen workers. We don't face ourselves in front of the patients. But whenever the patient comes with some diseases and I need to intervene, that means I am the treating physician for the patient. So I take each and every case as an interesting case. Memorable one case is, it was in my early stages when I was a postgraduate, when I and my guide, we both together treated a patient with large hepatic abscess. He was a young patient, around 18 to 19 year old, had multiple abscesses, had a complication with the abscess rupturing into the pleural cavity with a pleural effusion. We did drain him for 4 to 5 times, and after a span of almost 30 to 40 days, the patient recovered, and he came back and he thanked me. It was good gesture, because being a postgraduate, a patient coming and thanking you is absolutely heart-touching.
Yes, that's a wonderful case.
Yeah. Now it happens in each and every patient. It happens now because now we are doing it. It is easier, but the first case is always a best case. It's something like hitting a first century.
Okay. Nice. Yeah. So, what are some latest advancements and technologies in interventional radiology that you find exciting? Like, how do they improve the patient outcome? Any recent advances that has happened?
Not as in a recent advances. It is there for a long time, which I am not still into it. But really, a radiofrequency ablation and some chemoembolization for the HCCs, which has done miracles for the patients, because initially, as soon as we used to say any hepatocellular carcinoma, the thing is, it is an end stage for the patient. It is not like that now. We can just give him a radiofrequency ablation, give him a chemoembolization, prolong his stay for a longer time, and most of the people will come with disease-free intervals. That's good.
That's wonderful. So, sir, how does interventional radiology differ from other medical specialty? Like, what unique skills and qualities do successful interventional radiologists possess, in your opinion?
The one thing the interventional radiologist is keep intervention separate. We are the radiologist first. So, compared to the other medical fields, we know the imaging in and out. We are the one, we know that what is happening into the particular organ. Then automatically it is easier for us to intervene into that particular disease. That's the easier part. But compared to the physicians, surgeons, they are seeing the patient from above, they don't know what is happening inside. So as a radiologist, I know what is happening inside, and when I start intervening it's much easier for me because I know what I'm dealing with and which organ I'm dealing with. So each and everything I know in and out, so it makes the things much easier to intervene any of the things.
Nice. So can you share your career journey, including education path, training required to become for the upcoming medical students to understand which path they should take forward in their life?
I don't know, to be frank, for the MBBS students, there is some myth. I don't know, call it as a myth or something like that. The people get fascinated with the radiology thinking that it is something like
White collar.
Something like a white collar job. You go out at 4 o'clock. That is not the truth. Everything is not the money. They say it is the money. Everything is not the money. But the thing is, if you come into the radiology, you have to be a donkey. You need to work hard day in, day out to know the subject. Once you know the subject, you become a radiologist. Then you enter into the intervention. To have an intervention, you need to have a good hand skill coordination. It's something like a person hitting off drive. If you have a good skill, you are going to pursue in it. But only thing is, even the important thing is, you need to know how to speak with a patient. I always tell my postgraduates to be a clinical radiologist. Speak with a patient. Whenever you put even a simple needle, let it be a simple drainage of a 10 cc. Speak with a patient, gain a confidence of the patient. So even if you make a mistake, patient is going to forgive you. And if you don't speak with the patient, even a small needle, even if he does ooh, ah, ouch, then you're gone. You're something like you will be held like you are not a good doctor. So always see to that, be a good clinical radiologist, be a good to the patients, speak with the patients, gain a confidence, then automatically the radiology and the interventional radiology will come into your basket easily.
Okay, nice. So, what role does collaboration play in interventional radiology? Like, how do they work with other health professionals to provide comprehensive patient care, other departments?
Yeah, it's always good that most of the super specialties, especially. For example, I will tell you, in our department, in our hospital, gastroenterology is the department. There are some consultants. I don't know whether I go or not there in their department. Every damn day, those people are going to come into our department, they discuss, they get done their interventions done. So, most of the times which they can't do it, or let it be something like a simple pseudopancreatic cyst, they are not unable to drain it through the endoscopy, they come and discuss with us. And as soon as they say, they give us a guidance, go put a pigtail, come back, automatically as a part of a team. It is not something like a radiology is treating, it is a team of people who are there, a gastroenterologist and the radiologist together are treating the patients. It's good for the patient. It's always a good collaboration, always. It's not only the intervention, even a simple radiology. Let it be a neurophysician, neurosurgeon, or a simple surgeon, or a gastroenterologist, whoever it is, they always come to the department. The collaboration is always a must. Single-handedly, a radiology or an interventionist cannot treat the patient. Similarly, single-handedly, nowadays, a physician cannot treat the patient. Collaboration is always required.
Do you think there is a resistance in the other specialties to get help from interventional radiologists on the right time? On the right time, not when it gets worse, but on the right time. In your opinion, in your clinical experience.
This is something like a political question, and I would like to be a diplomatic. It is always be there. To be frank, radiology is a fascinating subject to the people who are not in the radiology. That is the truth of life. Not to the radiology people, because radiology people will get bored. Most of my postgraduates get bored of a radiology after 1 or 2 years when they are studying it, not when they are earning it. That is a different thing. But automatically the other people want to come into our radiology because endoscopy when they are doing, they want to know ultrasound because endoscopic ultrasound is there. So everyone wants to pinch into it and they want to keep stealing the things. Why I need to send a person? But to be frank, with respect to all the departments, they are good in their own way. But when it comes to the radiology, we are the one who knows in and out. We know the CT, we know ultrasound, we know MRI, and we know how to come to the diagnosis. So taking in the help of an intervention radiology is always good, rather than telling that we will take care of the things. So those things will be there.
Okay. Now a question for the students actually, upcoming radiologists or medical students. So could you describe the lifestyle and work-life balance of an interventional radiologist, like, including the challenges, rewards you have experienced in your career?
Yeah, I'm not a die-hard interventional radiologist to be called, because as I told you, I do mostly a non-vascular.
Okay.
When you do a vascular intervention, one of the things you are being exposed to the radiation. That you should be ready to sacrifice. You are going to get exposed to the radiation, a significant amount of the radiation compared to the general population. So you should be knowing the hazards of the radiation. And I always tell the people, be healthy. The most important thing is you work hard like a donkey for 8 hours. But rest of the 8 hours, among those 8 hours, give yourself a 2-3 hours for your health. That is most important. Sleep for 8 hours. If you sleep well, if you are healthy, whatever the 8 hours you are working like a donkey, you will work hard, and it will be a more fruitful rather than working at 10 to 12 hours. And in those 10 to 12 hours, you are working hardly, a fruitful is only 6 hours, and remaining 50% you are going to make mistakes. So always preferable is be healthy.
Okay.
Give your 100% in those 8 hours, but remaining 8 hours is your life. Don't give everything to everyone. That is not the truth.
Okay. And what's your advice to the students who are considering a career in interventional radiology or vascular radiology or something after diagnostic radiology towards an intervention?
Yeah, anyone who wants to have an intervention radiology as their career, the important thing is speak with the patient. Develop a good rapport with the patient. We are not robots that each and everything will be 100% success.
Yes.
Being a human beings, you are going to make errors. The errors is exemplified if you don't speak with the patient. The one error which is something like a significant big one can be considered as a minion if you have a good relation with the patient. The patient automatically says, no, don't worry doctor, nothing is going to happen, we'll take care of this. But if you don't speak with the patient and you don't face the patient, you come, you even don't see the patient, you don't take the patient's name, you come, you put a needle, you do, and you go out, some complications happens, patients are not going to take you lightly. They say, this doctor doesn't speak with me only. Now how he is going to treat me? And if such a complications happens, so it will be significantly exemplified. So it's always important that create a rapport, learn how to speak with the patient, become a good clinical radiologist, have good skills, and you need to spend more time in the department rather than into the books. Your YouTubes, your channels are not going to help you out. You need to spend significant amount of time in the department, working in the department. That helps you to give in a good intervention.
There is a myth among the final year students or like medical students who are preparing for NEET. They're targeting radiology, majority of them thinking that they don't have to interact much with the patient. They are on the backstage. So what is your message to them? It's I know you have told.
It's purely myth. It's absolutely wrong. Nowadays, we don't call it as a radiology. Even NMC, that's the National Medical Council, has changed the name into the radio diagnosis and imaging. And whoever is in the intervention or whoever is there, even a little bit of an interventions, not even a vascular, they always gives an importance of a clinical radiology. Speak with the patient, you have to work like a physician. If I'm doing a prostate biopsy today, I need to speak with the patient, I need to know each and every blood investigations of the patient, symptoms of the patients. I have to do myself a distal rectal examination. Then I will proceed with the intervention. It is not something like that as soon as the patient is sleeping, take a transrectal probe, put it into his back and start taking the biopsies. No, absolutely not. So it is a myth. So always you need to interact with the patients. If you are not interacting with the patients, none of the clinical departments are good. So it is better you go to the pre or paraclinical where you are going to interact with the patients, the students. You're there in the radiology, you need to interact. There is absolutely no way you can't interact with the patients in the radiology. Yeah. It's absolutely, as you said, it's a myth.
Okay, nice. That will be a message for medical students actually.
Absolutely. It's a good message for the students. They need to know that if they are planning to pursue in the radiology, You need to be good with the patients. You need to know how to speak with the patients. So always, that's a good thing.
Yes, sir.
Yeah.
And sir, within your busy life, I can see that even here to get this few minutes for the talk, you're very busy with your cases and all that. In between this, how do you stay updated with the latest developments and research in this radiological field and, you know, ongoing learning? And in between that, you're giving other talks to, you're doing the other researches too. So how are you balancing all this, sir?
The thing is, when you're there in the medical college, to be frank, I'm never into the corporate setup. In my whatever a short span of 13 to 14 years of my radiology journey, I'm never in the corporate setup. I'm always in the medical colleges. So the presence of the postgraduates is always in a plus point. I always say it is, I always keep not only learning by myself or my teachers, I always keep learning from my students also. So the learning is a continuous journey, it never ends. So the important thing is I keep updated myself by putting a difficult topics to my postgraduates. So I read and come. Automatically, even it will be difficult for them, but it will be a bit easier to understand for me. Automatically, I exchange my knowledge with them and we interact. So automatically, I keep updated the things. So automatically, it will be easier. When you have a postgraduates, your academics is always good.
Can you share a personal anecdote or a story that illustrates the impact of interventional, any procedure which you have done on a patient's life, which we can, you know?
Yeah, there are plenty, to be frank, because as I told you, each and every patient comes and speaks back to me, because as I told, even you can just ask in my department. Most of my postgraduates just keep asking me, how do you speak with a patient? Recently, there was a patient, almost around a 65-year-old female. She had a pyelonephritis with a significant retroperitoneal abscess, perihepatic abscess. So she was very apprehensive, she was very sick, she was not eating anything. So I decided to do intervention because she came for a pigtail and aspiration. So on the one day we did aspiration of the perihepatic abscess, but the important thing is I kept on telling in my all those recent, whatever the last 10 minutes, the way you speak with the patient. I spoke with the patient very friendly. I just kept on calling her as a mother, or something like that. So I told her there will be absolutely no pain. I used liberal use of an anesthesia. I aspirated the fluid. So we aspirated the perihepatic abscess, but there was significant retroperitoneal abscess was there. So we couldn't take her to the same session, so we decided to put her on the next session. So the next session was there. We have given appointment in the 9 o'clock. She directly told, I need the yesterday's doctor only. I don't want anyone to come to me. Until unless he is going to come, I am not going to enter into the city room.
Okay.
So all my other staff waited for me. I came at 9 o'clock. As soon as she saw me, she told, you have to be there inside. I am not going to get it done from anyone, even though it was not my day. So for the entire procedure, even though it was some my other colleagues who were doing the procedures, I stood with her, nothing like that. As maybe you can call it as a relative or something like that. I stood with the patient for the entire procedure. We did the procedure. To be frank, it was a serious infection. So we put a pigtail, we drained the abscess. She was comfortable. For the last 2 times she came for the follow-up, and literally I am telling you, she waited for 45 minutes to get an ultrasound from me only. And every time she comes, she bows her head and she says, it is because of you I am surviving now. So such a things will give a immense pleasure when, because most of the, as I told you, the myth is they consider us something like a background people.
Yes.
They don't consider us as doctors. But when you treat a patient and they start seeing you as a treating doctor, then automatically it is something like a goosebump effect each and every time when a patient comes and speaks with you and tells that you are the one who treated them, even though the treating physician is someone else. But you are the part of that management system which really helped the patient out.
I'm sure this story is going to inspire many of the residents.
Yeah, true. As again, I keep telling, speak with the patients. That's the one thing. And as you told, the myth, it's a pure myth. You have to speak with the patients.
Yes.
In radiology. You can't run away from the patients.
Yes. And finally, before wrapping up, what's your thought about the workshop that we are conducting today? Because when I came here with the proposal, you were very welcoming, for the medical students to get a chance about?
It's always good that we keep, as I told you, we belong to the one of the best universities in the country, and not only in the country, we are considered among the worldwide, the JSS HER, and we always focus on academics. And anyone who wants to come for the academics, we are completely open for that. And since we have 10 postgraduates per year, my postgraduates are keen to learn when any new things are coming on. And as I told you, we do have vascular interventions are there, but we don't do much of the vascular interventions. It's always good when someone comes and teaches us the vascular intervention. The students are always welcoming.
Yes.
We always welcome for such things.
Yes. Okay, sir. Thank you so much. Thank you for spending some time with us.
Thank you.